Now we move forward to the different segment altogether, and this is potpourri of interesting cases. And for this particular segment, may I have the privilege of calling upon the chairpersons, Dr. Munna Dash. May I have the presence of Dr. Munna Dash on stage, please? May I request the presence of Dr. Devika Chatterjee to please come up on stage, and may I request the presence of Professor S.C. Mondal to please come up on stage and to take their seat in the chairperson panel so that we can start off with this very interesting potpourri of the interesting cases. So I would request the following dignitaries to please take their seats in the staging area, requesting Dr. Munna Das, Dr. Devika Chatterjee and Professor S.C. Mondal to please be on the chairperson panel. And we have a few speakers of this particular segment. First and foremost, I will take the privilege of calling upon Dr. Madhu Shukla, ma'am, to please come forward to start off with the potpourri of the interesting cases. We have 5 minutes for the cases and 3 minutes for discussion of the same. So for the panel, may I request the chairperson, the following elite dignitaries to please take the chairperson panel so that we can start off with the particular segment. Yes. And I guess what a wonderful start it has been for the first day of EZ EGO 2023. And we have just witnessed 3 cases, 3 workshops right in front of us. And I guess if you have any questions, queries that you need to ask and clarify, our doctors will be here, I guess, keeping our finger crossed, because I know everyone is very busy and we are really obliged that you have taken out your time, and we are really happy and privileged that you are here with us. And we will again request a few moments of time. So that, yes.
Each of the speakers get 8 minutes.
5 minutes for their case presentation, okay, 3 minutes for discussion. Total 8 minutes. And I will request the speakers to please get your presentation checked with the technical team so that we can just move forward with the cases one by one. So we start off with the first case, and the speaker of this particular segment, the first speaker, Dr. Madhu Shukla. Ma'am, just a moment. Yes, it is not.
Yes. Okay. So I am going to present this patient of RVMI, and basically a combined left ventricular and right ventricular reperfusion injury post PCI. What happens exactly is on the factors on which the outcome of a primary PCI depends is a time factor when the ischemia occurred first and when the artery was opened. The time distance difference between this and the talent and technique of the operator, and definitely the disease process is going on inside the human body. So all these interact with each other to give the results. So this is just to show whenever there is acute MI, occlusion of artery, you can see this red area. This is the area at risk after occlusion. And this is the second one is the hypothetical situation, picture showing when we open the artery, we think infarct area is green colored and salvageable area is red colored. But what exactly happens is salvage area is much less, and a lot of muscle tissue due to reperfusion injury also is not functioning well, and the real benefit following reperfusion is this area which we have shown. So reperfusion injury occurs in a substantial number of cases these days also. It's very common in 50 to 60% cases. Usually it is not noticed clinically. But what I say, if you have successfully opened the artery and patient even after that goes in heart failure, then you should first think of reperfusion injury. When everything is all right, but patient is not all right, then you have to think about the reperfusion injury. Echo can pick up substantial reperfusion injury in 5 to 10% cases, and when these injuries have unfavorable prognosis. Reperfusion injury of RV or MI is not reported by echo. This is 46-year-old male gets acute chest pain in the early hours of April 30, 2023. He comes to the hospital. ECG shows RVMI and inferior MI, undergoes EAG and PCI of RCA. You can see the patient has presented with this ST elevation in AVR and V1, and in inferior leads 3 and AVF, and this is RVMI and inferior MI. The angiography shows collateral flow to RCA seen. You can see here. I will not spend so much time, 5 minutes is less for this case. So you can see occluded proximal area. You can see occluded proximal RCA and multiple non-critical codominant LCX, plaques in the left coronary system, and then the plasty was done. Stent in the proximal RCA with dye stuck in the RV branch. You can see that. Large patent RV branch and large acute marginal branch and small RPDA. So this is the RCA pre-procedure and RCA post-procedure. Echo was performed on the next day. You can see IVC is dilated and LV though functioning pretty well, but the red arrow is pointing an area which looks like moth-eaten area. What is that? You can still see better here. We suspect intramyocardial hematoma in the basal inferolateral segment. How to see it further? We did a contrast imaging, and you can clearly see that area which looked like moth-eaten, it shows no perfusion at all. So this is intramural hematoma with corresponding perfusion defect. And I tried hard to show the RV free wall, but it was not discernible. And so we showed in the contrast. You can see only the apex is contracting. And perfusion defect in the free wall, you can see RV free wall is not moving. These are further views. RV free wall is not perfused. Apex is well perfused. You can see this. This was the ECG after the PTCA. And so this is myocardial hematoma in the basal inferolateral wall, RVMI, and reperfusion injury involving mid part of the RV free wall. These are 2 ECGs, just we have shown. And these are still pictures to show the this moth-eaten area, which is exactly, in fact, hematoma. You can see here further more pictures.
So you can sum up.
Yeah. I will just. RV reperfusion injury following PCIs is not reported because of RV wall is very thin. However, sometimes there is marked edema due to reperfusion injury, and hence perfusion defect can be seen. It can present as right heart failure without symptoms or cardiogenic shock. This is some mechanism. Whenever there is reperfusion injury, the arteries, they get swollen, their junctions of the cells, they open, and the plasma and RBC, they ooze out, and they cause collection of the blood in the tissue itself. That's all. Thank you.
So, we can just ask the question now or at the end of the session? What is the protocol? Okay, so nice presentation from you, Dr. Madhu. Only the thing is that what you showed in the post-PCI angiogram, we saw that the RCA didn't have a TIMI3 flow. Okay, leaving aside that the blush. The blush was not there at all, so it was possibly a late presentation, what I presume. And even post PCI, we didn't get a TIMI3 flow because there was still slow flow in the right coronary artery. So if we get a suboptimal PCI result, obviously that translates into a delayed recovery of the myocardium or non-recovery of the myocardium at all.
Definitely.
Then how do you in particular diagnose reperfusion injury in such a case when you already have a suboptimal PCI result?
No, it was very good. It's not that bad.
If you see the angiogram, it was not a TIMI3 flow. There was still a slow flow in the right coronary and there was no blush. Because a tissue level perfusion is ensured only with a good myocardial blush that we always notice, particularly in the LAO view as also in the epicranial view. Now, issue is reperfusion injury, I think, is very difficult to diagnose per se, clinically. And even through echo, certain leukocyte targeted myocardial contrast scans and your myocardial contrast echoes are there. Some papers are there, but I don't think clinically we can judge. But obviously, we can always prevent a reperfusion injury by treating the patient on the table itself through giving ample adenosine on a temporary pacing backup or giving a nicorandil and other micro vasodilators so as to open up the tissue level perfusion. That we have to achieve.
Reperfusion injury is very common, sir. It is very common. We have a series of cases.
I just want to make a comment. Whether you use CMR or echocardiogram, reperfusion injury is first characterized by myocardial edema. Large amount of fluid moves out of the capillaries and that wall gets thickened. And when the capillaries burst open, then you get hemorrhage. And hemorrhage is when that whole collects, the hematoma collects, it becomes echolucent. So both, in this case, first thing is the walls are markedly thickened, that area. You saw the RV wall is so much thickened, is thicker than the, so we know that the reperfusion injury, there's no question. I mean, the work from Hiroshi Ito from Japan has clearly shown that if an area remains ischemic after PCI, wall thickness will not change or will decrease. Why volume? Because 6% of the volume of myocardium is blood. You are not sending blood, the wall will be thinner. When wall is thicker than 15% of adjacent wall, it indicates presence of myocardial edema, the first sign of reperfusion injury. Here the wall is so thick, RV wall is so thick, and the basal infralateral wall is twice thick compared to the mid wall, we clearly know that edema is there. In addition to edema, and whenever there is edema, capillaries will get, some capillaries will burst, and the other capillaries will get compressed because of hydrostatic pressure, leading to no perfusion. No perfusion can occur both in ischemic injury and reperfusion injury. Reperfusion injury is separated by presence of increased diastolic thickness representative of myocardial edema.
We have been picking up with the echo and we have lot of cases, and this kind of injury is the one which makes thick.
What I wanted to tell is that if you have a suboptimal PCI result, then can you separately point out a reperfusion?
But here the wall edema
So
is too much.
you can have a suboptimal result and then you are left with residual ischemia. There the wall will not thicken. See, reperfusion, that is why there is a overriding, or let us say straddling term called ischemia reperfusion injury. In this particular patient, this is ischemia reperfusion injury. Part of the injury is ischemia because, as you said, flow is not TIMI3. That is acceptable. Part of the thing is reperfusion. What blood has gone, it has actually, the capillary hydrostatic pressure was so much that it has swollen up the myocardium on right side. But the capillaries did burst open and produce a hematoma. Hematoma is always echolucent. A lake of Echolucency is always hematoma, nothing else.
Thank you, Dr. Madhu. So we can call the next speaker, please.
Thank you so much for your contribution to AZ Eco 2023. Now we move forward with the next speaker, Dr. Nandita Chakraborty. She will be the next speaker. And on the chairperson panel, we have the presence of Dr. Shorangshu Chatterjee, Dr. Munna Das, Dr. Devika Chatterjee, and Professor S.C. Mondal. So now, off with the next speaker, Dr. Nandita Chakraborty.
Good afternoon. Okay, just enter, no? Yeah. I'm just going to present a couple of rare complications of myocardial infarction. Now, my first patient was a 60-year-old female who came to our ER. She had no significant past history, had been admitted outside with chest pain in a remote hospital. She was diagnosed there as an inferior eval MI, was being treated conservatively, developed sudden SOB, and then she came to us. When she came to ER, she was in cardiogenic shock. So this was her ECG, this was the pre-admission ECG. And after that, we got to do an echo on her. And this was the echo done in the ER itself. What you can see here is, can I have the pens here? Here, you can see that the anterior mitral leaflet is completely flail, and it's just going down into LA, and there's a huge gap left there during the systole. We put some color, and this was what it was, a riot of colors, severe torrential mitral regurgitation. Unfortunately, we could not do anything for this patient because the patient left against medical advice and did not come back to us. The second patient was a 44-year-old female with diabetes. She was being treated for UTI for the past several days. Again, she also developed shortness of breath and worsened. There was no history of chest pain, and she came to ER with bilateral clefts. This was her ECG. It showed inferior wall MI of some duration. And when we got to the echo, this was what it was. There wasn't much on the plaques view in 2D. There's some pericardial effusion and the left ventricle function was down. But if you look carefully, you'll see that there is something going inside LA with each beat. So we tried other views. In the parasternal short axis view, what we found was global hypokinesia, but the inferior wall was a little akinetic, with this papillary muscle appeared to be eaten away. You have a good papillary muscle head here, but the posteromedial papillary muscle is affected. The next view, a little off axis, gave us this picture. You can see the caudal, there's a caudal flail caudal just going up and down here. The anterior mitral leaflet has lost its support, and this is how the ventricle is behaving now. Again, severe mitral regurgitation. Another view, you can see that the patient here also is showing severe mitral regurgitation. LV function is depressed, RV function is depressed, there's a pericardial effusion, and RA is tense. She probably has developed a lot of PAH also. The third patient was a 60-year-old male. He was a known case of hypertension and diabetes. He had been feeling a little off color for the last few days. He presented to us with shortness of breath, sweating, and nausea. ECG revealed inferior wall MI again. This patient also was in early CKD, so in view of his raised creatinine and late presentation, he was being treated conservatively in the hospital. On the 5th day of hospitalization, he suddenly developed severe shortness of breath and became hypotensive and then went into cardiogenic shock. Was intubated, and the ECG was showing, this was what the ECG was showing, some inferior wall injury with complete heart block. And echo, this is again an off-axis view. You can see this is a mitral valve, and this is part of the inferior wall. And look, there's a huge gap here in between the two ventricles. There's the left ventricle and the right ventricle. The septum has just blown away. And that was the reason of his sudden deterioration. A still picture to show how big this defect is. It measured about 2.3 millimeters. And here is the flow across the defect. So this is a case of ventricular septal rupture. And his PA pressure, if you no, I just want to play this. Yeah, thanks. If you look carefully, you will see that the flow is, there's no gradient. So? Yes, sir, there is some flow in the right ventricle, but what I wanted to show was the flow across the defect. And the flow across the defect is not turbulent, which is why he did not even develop any murmur. The reason being this high PA pressure which he developed. Unfortunately for us, this patient succumbed. We could not do anything to him before we could even prepare him, stabilize him or prepare him for surgery. So that was the story. Now, fact sheet about these complications of MI. They're very rare complications. But ruptured body and rupture of papillary muscles occur both in STEMI and non-STEMI. So they usually occur a little late in the day. They may occur on the very first day, but usually occur around 3 to 5 days. The posteromedial papillary muscle is involved because of a single coronary supply. And the infarct size is not the factor, but it's the site which is more important. 50% of these patients have a single vessel disease. The classic presentation is always decompensated heart failure, and the management is stabilization followed by an emergency surgeries. These patients also, revascularization is important for these patients because they do well only when revascularized along with mitral valve surgery. Ventricular septal rupture occurs in less than 1% of patients with MI. The incidence was higher before, when reperfusion was not such a hot thing, but now most patients are getting this facility, and so the incidence has become less. They're mostly seen in anterior MI. 2/3 of these patients are in anterior MI and 1/3 in the inferoseptum. They occur late in the disease process, around 1 week down the line they usually occur. Again, there is sudden hemodynamic instability. Maybe there's development of new murmur depending on the size of the ventricular septal defect and the right ventricular pressure. Cardiogenic shock, all these things should raise a suspicion, and really it has to be looked for. Otherwise, we might as well miss these findings. This has a higher mortality rate. These patients, stabilizing these patients is a real challenge. Again, the management is stabilization and surgery as soon as possible. The differential diagnosis could be severe biventricular dysfunction and extension of infarct or a fresh infarct in a region. Free wall rupture. One of the causes could be hematoma, as Dr. Madhu just showed, causes of free wall rupture, giving rise to tamponade.
You can just sum up.
Yeah, it's done. My take-home message is this. These complications of MI are rare, but life-threatening. So you need to, if post-MI sudden heart failure, sudden change in status should raise a red flag. You should look for them, recognize, evaluate, and intervene early. And with those, it can save lives, like we saved the second patient. Thank you so much. That's it.
Thank you, Nandita. You have shown all the cases very nicely. you have shown how to get the post-inferior wall MI VSR out of the off-axis view. That is very important. It is very easy to pick up post-anterior wall MI VSD. But in inferior wall, always we go for the off-axis view from the fourth chamber. So you have shown it very
This
nicely.
patient, there was nothing from the fourth chamber.
Yeah.
It looked like almost a normal ventricle. So, but the moment we moved our transducer, we could see this. But I would like to put in a word about the apical VSDs also. They are also not, because they get tucked away and they are so near, close to the apex. Unless you are really looking, zooming, optimizing your machine, you will not get to see those also. Becomes difficult. And
There
not
again
picking-
comes, we should always auscultate the patient before doing an echo.
Yeah, this
The
patient did
importance
not
of
have a
auscultation.
murmur also. I accept the tricuspid regurgitation murmur.
Thank you, thank you.
Yeah, thank you so much.
So we conclude this particular session by Dr. Nandita Chakraborty. I would extend thankfulness for her contribution to EZ ECO 2023. Now we move forward with the next speaker on house. May I have the privilege of calling upon Dr. B.R. Mishra on stage for presenting the next case.
Good afternoon, everybody. And this East Zone Conference, I represent Odisha. And I thank Dr. Soumitra Kumar and Dr. Bhattacharya for inviting me. So this is a very interesting case. My first slide is a quiz, not for stalwarts. It is a parasternal short axis view. Well, this is a patient, 46 years female, who presented with dyspnea, and he had positive findings as cardiomegaly, wide split second sound, loud P2, and prominent murmurs in the precordium. So the ECG is significant in the sense that it has sinus rhythm, first degree epiblock, and left axis deviation. Chest X-ray shows cardiomegaly, prominent central and hilar pulmonary arteries, and evidence of increased vascularity. And this apical four-chamber view, you can see the descending aorta, on the left side. Yes. And apex on the left side is the situs, soleus, and levocardia. And it is a classical view of a partial atrioventricular septal defect with a large primum AST and two separate AV valves at the same level. Now there is a left to right shunt across the ostium primum AST. If I tilt the probe a little further, I could find a ostium secundum AST also associated with it here. And color Doppler shows the shunt across this secundum and also across the primum AST. Now coming to the color Doppler of the AV junction, there are two regurgitation, right AV valve regurgitating to the left atrium and left AV valve regurgitating to the right atrium. So the jets cross each other to reach the opposite atria. And this is the slide I have shown in my first slide as quiz. Now the diagnosis is obvious. There is a cleft in the left AV valve. You can see a separate as a gap here in the left AV valve. We don't call it a cleft mitral valve because it is the left part of the common AV valve. So the regurgitation, all we know, occurs through the cleft of the left AV valve. And it is clear in this picture also. Now the left ventricular outflow tracts are narrow and elongated. This is called a gooseneck deformity. This is also here. And normally the distance from the apex to the mitral annulus and from the apex to the aortic valve are equal in normal cases. But in gooseneck deformity, in AVSD, there are no separate AV valves, so that the aortic valve sprungs anteriorly, causing a gooseneck deformity. So this is the picture I have, my picture that is playing, and the other pictures are from the books, and it is very classic gooseneck deformity shown in the angio and echo, and all the examples are here. And there is no LVOT obstruction because that is also expected here. And there is papillary muscle dysfunction, papillary muscle deformity. Normally it is 8 to 4 o'clock position, it should be there, but here it is counterclockwise rotated to 3 o'clock to 7 o'clock position. Now the RA pressure is normal, appears from the IVC dimension, that is collapsing. The TR gradient is high, indicating pulmonary hypertension, and pulmonary artery is dilated because of the shunt and because of the pulmonary hypertension. So I have calculated the estimated PA pressure, and this PA pressure is a combination of pre and post capillary pulmonary hypertension, because of pre-capillary because of the shunt, and post capillary because of the AV valve regurgitation and increased LA pressure. So this classification is WHO group 5. Now the ventricular functions appear good visually, and also the S prime in the tricuspid, the TAPS, the EF are all fairly good. So this is a case of adult CSD, situs solitus levocardia, partial AVSD, large ostium primum and ostium secundum ASDs, left to right shunt, right-sided volume overload, cleft AV valve, severe, moderate to severe AV valve regurgitations, jet crossing to opposite atria, gooseneck deformity, papillary muscle deformity, pulmonary hypertension group 5, good by ventricular function, sinus rhythm, first degree AV block, and NIH class 2. Thank you very much. Cleft.
That is important for surgery.
I have not seen it. Yeah. This is the short axis and the parastomal short view. This is the left AV valve. This is a trifoliate AV valve, it is called. This is the incomplete fusion of the superior and inferior bridging leaflet, which is seen as a cleft. So the cleft faces the ventricular septum. But if it is not AVSD and the cleft mitral valve, it faces the aorta anteriorly. But in AVSD, it's cleft AV valve, it faces the septum because the incomplete fusion of the superior and inferior bridging leaflets.
Actually, the left mural reflex.
This is the cleft.
If it is small, then there will be some residual problems after OT.
Yeah.
That is why a good size left mural reflex, widely spaced papillary muscles, is good for the surgeons.
Yeah. No, I don't have a facility for 3D. I don't have.
In fact, when the papillary muscles come very close, it was a parachute mitral valve.
Yes.
The greater the gap between the papillary muscles in the short axis view, the greater is the outcome after surgery.
Yeah. But 3D will be more typical classical of a cleft mitral valve.
Thank you.
Thank you.
Any questions from the audience?
Yeah. I can hear. Rastelli classification is for complete AV septal defect. Here it is a partial AV septal defect. So there are two separate AV valves. In Rastelli classification, it is a classification of complete AVSD depending upon the caudal attachment of the cauda to the septum.
This is a bridging leaflet, it is attached to the septum.
Yes.
You can't classify them.
So Rastelli classification doesn't applicable in this type of purely ostium primum ASD septal, the atrial septal defect and ventricular AV valve regurgitations. There is no VSD here. So Rastelli classification appear when there are inlet VSD associated also.
Any more questions? So with your permission, then we close this particular session. Thank you so much for the contribution to EZ Eco 2023 to Dr. B.R. Mishra. Now we move forward with the next speaker of this particular topic, that is potpourri of interesting cases. May I request the presence of Dr. Dhritobroto Dash to come up on stage for the next interesting case.
Good afternoon. After this nice presentation of an adult congenital heart disease by Dr. Mishro, I will take you to a congenital heart disease of a child and then to a fetus if permits. So the first one is an anatomically corrected malposition, which is an rare anomaly itself, and you may not all be familiar with this terminology, and I will present an undescribed variant of this particular anatomical malformation. So what is anatomically corrected malposition of great arteries is that the concordant ventricular arterial relationship. So left ventricle is connected to the left atrium, right ventricle is connected to the right atrium. Left ventricle is giving rise to the aorta and the right ventricle is giving rise to the pulmonary artery, but the relationship of these great arteries in the superior mediastinum is not normal. So there is an abnormal spatial relationship of great arteries in the superior mediastinum. So the case is a 5-year-old girl who was completely asymptomatic, and incidentally murmur was detected, and there was a 4/6 pansystolic murmur. The chest X-ray showed mild cardiomegaly, and the ECG was otherwise normal. The outside echo mentioned that there is a VSD and was referred for further management. Now, the videos. None of the videos.
অডিও তো বড় না, ল্যাপটপটা তুলছে না, একদমই তুলছে না।
Requesting a few moments of time, as we just need to clear out the technical glitch for this some time. So I will request a few moments of time till we get through this.
এর অপশনটা কোথায়? উইন্ডো।
And I would request the upcoming speakers to please get your technical run dry once, so that we can move forward with the case studies one by one.
But we checked it in the initially also that it was running, but now they're unable to connect.
So from the permission of the chairperson panel,
the
should
next
we
speaker
move
can
forward? Okay. Okay, so we need some time for this technical glitch to be amended. I would request the next speaker to please come up on stage with the presentation. May I request the presence of Dr. Deepanjan Bhattacharya to please come up on stage so that we can move forward with the next case study, and we will be again back with Sir with the presentation of the potpourri of interesting cases. Sir, your mic.
Hello, good afternoon to everyone. So I'll be presenting an interesting case. So it's a case of mitral regurgitation in a young man. Although it seems simple at initially, but I'll show how different it turned out to be. So we have a 25-year-old male presented with dyspnea on exertion for the past 1 week. Initially it was class 2, then progressed to class 3 to class 4 within a period of 1 day. Two pointer. Okay, so we have a 25-year-old male who presented with a history of dyspnea on exertion for past 1 week, initially class 2. Then within a period of 1 to 2 days, it progressed to class 3 and then class 4. And there's no history of pedal edema, angina or palpitations. He had some painless swelling in the neck around 1 month back, for which he took some indigenous medications. He was diagnosed outside as mitral valve prolapse with severe MR, and he was referred for MVR. So clinically, he was alert, conscious, cooperative. He had tachycardia with a normal volume, blood pressure of 116 by 76. Saturation was 90% in room air, which improved with to 98% with oxygen and NIV. No bipolar edema, no organomegaly, no cardiomegaly clinically on examination, and he had a quite prominent LVS3 and a 3 by 6 PSM at the apex, which was radiating to the axilla. So his 12-lead ECG showed a sinus tachycardia, and there was no significant LV or LA enlargement. Chest X-ray showed pulmonary edema. There was no cardiomegaly as such. Now coming to the echo, initially the screening echo, it looked very simple, severe MR, MVP of AML prolapse to the LA. So if we see the plaques view first, it seems very simple. But here, if I may point out, we can find that there is some mass-like structure which is moving, which is just behind the PML. So again, on this view, we can see that there is some aneurysm-like structure which is just located in the submitral area. So he was admitted, and here in this view, in the plaques view, we can find that the PML attachment is normal, but there's an aneurysm-like structure just below the mitral apparatus. So we thought that it might be, we had two differentials in mind. Either it can be a mitral annular disjunction or a submitral aneurysm. So he was initially stabilized with non-invasive ventilation, diuretics. His CRP and ESR were elevated. He started on antibiotics. Blood cultures were sent. But in spite of all this, he crashed and had to be intubated and started on mechanical ventilation. However, it was a boon for us because then we could proceed with the TE. And on the TE, we can find that at 0 degrees, the mitral valve apparatus looks normal. But here, we can see that there is a submitral aneurysm. And here, we can find that the MR looks around moderate. But on this view, due to the submitral aneurysm, it has become a bit severe. These are the further views at 76 degrees and 115 degrees, where we can make out that the submitral aneurysm is quite clear. And this is the 3D view. Again, we can see that the mitral apparatus is otherwise fine, but there's a submitral aneurysm which is hiding just beneath the valve. So these are the other views which show the same. So to further clear our confusion, we went ahead with a cardiac CT. And here we can find that a clear-cut submitral aneurysm. And it is better seen on the coronal views. So he was shifted for surgery, and he underwent the submitral aneurysm was excised and repaired with an autologous pericardial patch. And these are the intraop images of the same, where we can see the area where the submitral aneurysm is located. And he underwent MVR with a 25 by 33 Onyx valve. and post-operative course was uneventful. And during this period, his MAN2 had turned positive. So we found that there's an association of this submitral aneurysm with tuberculosis. So he was started on anti-tubercular therapy as well. And on the histopath also we found this was the specimen which was excised. And there were focal myxomatous changes, but there was extensive granulation tissue and multiple foci of epithelioid granuloma with Langerhans giant cells. However, the stain for AFB and fungus was negative, and the tissue culture was negative for bacteria and mycobacteria. So on follow-up, he was class 1, the mitral valve gradient was 7/4 at a heart rate of 64, and he was continued on antitubercular therapy. So submitral aneurysm is an extremely rare cardiac pathology. There are limited case reports about this in literature. Predominantly, these reports are from Africa. And the pathology predominantly involves disjunction between the left ventricular musculature and the left atrium at the mitral valve region. So either it is congenital or associated with Takayasu arteritis or tuberculosis. And they may be asymptomatic or present with mitral insufficiency. However, prompt diagnosis is by imaging, and I must stress the importance of transesophageal echo in these cases for the diagnosis and successful treatment. Thank you.
Myself, I have just learned a new thing, and it is the first case I have seen actually, submitral aneurysm. Thank you.
Well, in this it is, congratulations. But
Thank you.
despite that, the etiology remains uncertain. What do you think could be the etiology? And often we get the mycobacterial positivity by gene expert state when
Yes,
the usual
yes.
tests do not successful.
Yes.
So did you do that?
Yeah, it was done. I just forgot to mention it. We had sent both his bronchoalveolar lavage after intubation as well as the cardiac tissue for gene expert, but both were negative. He was a Ayurvedic practitioner, and he was taking some Ayurvedic medications for the past 1 month before coming to us. And he had a history of swelling in his neck, but it improved with whatever treatment he had taken.
Could it be lymphadenopathy or something?
Yeah, probably it was TB lymphadenitis which had led to this development of the submitral aneurysm. But we don't know, the associations are
Whether
yet unclear.
ultimately it is mycobacterial or non-specific.
Yes.
Could you ascertain or give AT drugs empirically?
No, actually there are no clear-cut guidelines. So initially when we went through the literature, when we started, we found that there's an association, and when he had that history, we started. But after when the histopath came, we found that there were Langerhans giant cells, which are pathognomic of tuberculosis. So we continued him for the phase of anti-tubercular therapy.
Thank you so much.
Thank you. Yes.
The case you have just described, we always used to think that these aneurysms are congenital, traumatic, roadside accidents. Syphilis also used to. I think the tubercular pseudoaneurysm was first described from India in American Heart Journals back in '82 by Satyavan Sharma.
Yes.
So we got interested. You might have read that paper also.
Yes, sir. Yes, sir.
Yeah. So we got interested in that, and then every time these kind of thing was seen by us, and we got the patient operated. In fact, the surgeon always said that the surface was studded with tubercles.
Yes, sir.
The pericardial, the moment you removed the pericardium, it was studded with tubercles. So we do feel that submitral aneurysm in this country, tuberculosis has to have a strong
Yes, sir.
possibility. The other thing, of course, besides of course post MVR, the other thing is roadside accident.
Yes.
Roadside accident is the third cause which we have seen. Congenital, of course, Bantu's aneurysm, as it was described long ago, we all know about it. But the tuberculosis in this country continues to be the single most important thing after post MVR.
Yes.
So thank you for your nice presentation. Yeah. So we can call the next speaker. Yeah.
Yes, as the technical glitch has been sorted now, we will again have Dr. Ritubrata Das to take over his interesting case.
Yeah, I hope the rest of the presentation will be okay. So we stopped by describing the clinical presentation, and let me go to the echo pictures. So you can see that there is a situs solitus with a levocardia, and the left atrium is collected to left ventricle, right atrium to right ventricle. So there is normal concordant AV connection. But when we go to the parasternal long axis view, you can see that the aorta is arising from the left ventricle as a normal parasternal long axis view, and you can see a VSD also. When we are modifying the long axis view to look at the right ventricular outflow, we can see the pulmonary artery, and it is connected with the tricuspid valve, and I don't find any subpulmonary conus. So it looks like that the mitral, the tricuspid and the pulmonary valve in fibrous continuity. So the pulmonary artery is anterior rather than the posterior. And surprisingly, this is the short axis view, parasternal short axis view, which shows the inversely related great arteries. So instead of the pulmonary valve being anterior and to left to the aortic valve, it is anterior and to the right of pulmonary aortic valve, which we see in inversely related great arteries, usually seen in case of situs inversus. And you can see that there is a muscular VSD in the anterior muscular septum, and you can see that in the parasternal modified long axis view as well, which measured about 5 millimeter. And the echocardiographic diagnosis was situs solitus levocardia with concordant AV and VA connection, but the great arteries are inversely related. So by segmental nomenclature, it becomes SDI. So situs solitus, D-looped ventricles, and inversely related great arteries, and there is an anterior muscular VSD, mild dilatation of the left-sided cardiac chambers without any pulmonary hypertension. The baby was taken for VSD device closure also, and you can see the angiographic pictures. In this right side, the still picture, you can see that there is a VSD, and you can see the great arteries looks more or less parallel, and the coronaries are possibly of a common origin. We tried to see it better, and if you look at this picture, it is the elaeocaudal view, and the right coronary artery is actually anteriorly crossing the pulmonary artery. And you can see in the right-sided picture that there is a parallel great arteries instead of the normal crisscross great arteries. This is the post-procedure echocardiography, which also nicely described that the VSD is closed with a device, and the great arteries are parallel to each other. So let me go to the discussion. The anatomically corrected malposition is a very rare congenital cardiac anomaly, and according to the Van Prux classification, there are usually the 4 varieties which have been described in the literature: SDL, SLD, IDL, and ILD. This particular variety, which is SDI, has not been described in literature. I could not find any reference to this particular combination of abnormal ventricular arterial connection. Similarly, another possible anatomically corrected malformation will be ILS, where it is in situs inversus L malpose great arteries with a solitus great artery relationship. Other possible varieties are if there is the situs is ambiguous. In those cases, it is also possible, although the case has not been described in literature. Associated cardiac abnormalities are common with anatomical corrected malformation, as we have found an VSD in this particular case. So that's all here, and any questions are welcome, and I'm happy to answer if I know the answer.
In the parasternal short axis view, your picture was looking like CTGA. The aorta is anterior and to the
Now, actually, sorry to interrupt. Actually, in CTGA or L transposition, aorta is anterior and to the left. Here, it is pulmonary artery is anterior and to the right. Aorta is rather posterior. If you look at the pictures again, I'm playing them again. It is we see in case of situs inversus, where the pulmonary artery is anterior and to the right of aorta.
This is the picture we get in CTGA, isn't it? The same picture.
No, CTGA aorta will be more anterior. If you look at the parasternal long axis view or the angiograms also, the aorta is not anterior. In CTGA, aorta is anterior.
So anterior posterior makes the difference.
Anterior posterior makes the difference, right? In DRV, we get parallel great arteries, but the great artery relationship is not inverse like this one, where the pulmonary valve is actually, if you look here also, if you look at these long axis pictures, the aorta is arising normally, but if you look at the pulmonary artery, it is not the tricuspid and pulmonary usually you don't see in the same frame. If you go posteriorly, you will usually see the tricuspid valve opening up, but it is the anterior angulation from the parasternal long axis where I can see both the pulmonary and tricuspid, and most likely there is no subpulmonary conus. The infundibulum is possibly absent. Yeah, absolutely.
In the same heading, what you showed that left and right or side by side little bit of orientation, rear and side by side both will come in same group, and it is rare, very rare, and I am going to show in next tetralogy. So it does happen, possibly getting less.
So if time permits, I will show another case, otherwise we will move on. Okay, fine. Thank you.
So we thank sir for your contribution to EZ ECO 2023. We move forward with the next speaker, and may I request the presence of Dr. Paramartho Bhattacharya sir to please come up on stage. And the last topic of this particular segment, that is potpourri of interesting cases, is taken by Dr. Paramartho Bhattacharya.
Well, this was an 18-year-old male patient and was complaining of increasing shortness of breath for more than a month. 3 years back, he was operated for a LA myxoma. On examination, the pulse was 122, blood pressure 108/68, and conspicuously the superficial neck veins were very engorged. So this was the chest X-ray. We thought we are dealing with a case of superior vena cava syndrome. So there was nothing in that. This was the old echo report that the patient showed us. There was a left atrial myxoma, and this was the frame of those old echos. But this time the echo showed this. This was the echo that we saw, and this was definitely a right atrial myxoma. So it was operated. The myxoma showed almost the same lobulated structure as it was shown in the echo. The post-op echo was done after 3 months, was absolutely normal. 2 years later, the patient came for a routine follow-up, and this was the echo. The patient again had a recurrence of a right atrial myxoma. You can well understand that the myxoma looks different than the previous one, and the patient underwent a thoracotomy for the 3rd time, and this time it's a lateral thoracic incision. 4 months later, the follow-up showed this. Yes, I'll show that, madam. This was, when I had reported the previous time, I thought that it was a bilateral myxoma, and there was a small thing in the LA, but when the surgeon operated, he said that he didn't find anything such. Only a few months later, the patient presented with such a bizarre finding. Well, left atrial myxomas are primary cardiac tumors, most common benign cardiac tumor, 80% of all tumors. Most common site of the atrial myxoma is in the left atrium. Commoner in females between the 3rd and the 5th decade of life. Tumor recurrence is common in males. The first recurrence was described by Jabode in 1967, and the main symptoms are that of heart failure, pulmonary edema, PND, thromboembolism causing syncope. We had PND in our patient. Recurrent atrial myxomas, however,
is uncommon following surgical resections. Resection is about 1 to 2% in the familial cases. Recurrence is uncommon in sporadic cases. Recurrences occurs during the first 3 or 4 years. And it is mostly pathophysiologically due to inadequate resection or totipotent multicentricity, inheritance, which is a familial type, sorry, not a family type, familial type, and metastatic recurrence are also postulated. My second case. The 16-year-old male patient was brought to my OPD by his father with the complaints of interscapular pain, dull aching chest pain, pain radiating to left arm, family history that his father had an inferior wall MI just a year back and underwent a primary PCI in the RCA. He thought that his child should also get examined. On examination, the pulse was 112, blood pressure 140/88, SpO2 was normal in room air. Anemia, cyanosis, clubbing was nil. The patient was a tall boy, 186 centimeter, weight 102 kgs. CVS was absolutely normal, nothing on the abdomen. The ECG was this, a little bit of ST changes in the V1, V2, V3, acceptable in perhaps this age group. The patient's ECG was fairly normal and I was convinced that this was a musculoskeletal pain and took the patient to the echo lab most reluctantly only because the father has requested to. And in my echo, I saw this. No, this was the first, this was the echo, something in the RV and mostly in the apical side. And this was again a different sort of a mass it looked like, and if you see that there are two different masses, one in the apical part and one in the RVOT. To my diagnosis, actually this child was a friend of my eldest child and his father was also, we had a family relation. So when I first saw this patient in my echo clinic, it was a cold chill down my spine. So I thought it was an RV clot in a case of ARVD. And the DD was of course an RV myxoma with an RV apical clot. This was the CT finding and it showed two different masses, one in the apex and one in the RVOT, and the same report has been given in the reports that there are two separate masses, one in the RVOT and one adjacent to the apex. The LV ejection fraction was a bit low, 56%, RV ejection fraction was 36%, and this was the other cardiac MRI. It also showed that non-dilated LV with a LV ejection fraction of 48%, dilated RV with a RV ejection fraction of 29%, well-defined mobile soft tissue mass in the RVOT and the RV apex attached to the septum and the anterior wall, no myocardial inflammation, infiltration or infarction seen. So diagnosed as an ARV myxoma and operated in a hospital in South India. The first follow-up was this, and the patient was doing well. No more masses were seen, and if we want to learn a bit about RV myxoma, it was primary benign tumor, cardiac tumors of the RV, far more common in the far more uncommon and accounts for only 3.7% of all cases, mostly found in elderly. Major clinical consequences are arrhythmias, pulmonary embolism and sudden death. Any sign of RVOT obstructions need an urgent surgery. Imaging necessary, echo, CT, MRI, all needs to be done before the surgical planning is done. Surgery is done by the RA approach and the resection is done to the tricuspid valve. May need an RV ventriculostomy if there is an RV obstruction and the incision is along the RVOT. Incomplete resection is a problem. That's all. Thank you.